Monica Molenaar. I'm one of the co-founders of Alloy, and thank you all for joining us today. We're really excited about being out there and helping women find better information and solutions to their menopausal symptoms. That is why I founded Alloy. I went through this, started going through this problem myself almost 10 years ago when I had my ovaries removed after a BRCA diagnosis, the breast cancer gene diagnosis, and I decided to prophylactically have my ovaries removed, which sent me into menopause overnight, and about 5 years of trying to find the information, find the right doctors. And I realized what a tough problem this is for women. We'll go through why it's such a tough problem. But what we're doing at Alloy is really scaling the expertise. So making the expertise of menopause literate doctors available to women across the country, as well as the solutions, both hormonal and non, for menopausal symptoms and just sort of the menopausal phase of life, which also includes community and ongoing support for women. So that is Alloy. We are excited to have you here. Thank you for joining us. We also have a coupon code that we will share at the end, and I'm going to turn it over to Dr. Menn, who is one of our expert doctors on the Alloy platform, and she has been through this several times herself and can is a great resource. So thank you, Dr. Menn.
Thank you for having me. And I just want to note, Monica, people can put their questions in the Q&A, right? Or the chat.
In the Q&A. So we actually disabled the chat for questions so that we had one place to look. I will be monitoring those questions and we'll read them to ask them of Dr. Menn at the end. So we're definitely going to try and go through this quickly and have time for questions.
Great. So let's get started. Okay. And so again, yes, I'm Dr. Corinne Menn, and I'm board certified OBGYN and North American Menopause Society certified menopause practitioner. And like Monica said, I myself went through menopause 3 times due to cancer treatments from breast cancer diagnosed at the age of 28. So I really get all of the menopause symptoms because I've dealt with them myself. So let's just start with the basic definitions. Super important. What is menopause? Menopause is defined as 1 year without your period, and it occurs when your ovaries no longer are producing estrogen and progesterone. The average age is 51. It's about 45 to 55 is the range, the average being 51. Early menopause is defined between 40 and 45, and premature menopause is less than age 40. And really all of the symptoms that patients experience are caused by that loss of estrogen. And then perimenopause is just simply that transition time leading up to menopause. So it can last a decade or more, and it can frankly start as early as the mid-30s. And often we find women are particularly symptomatic then because of all of the hormonal fluctuations. Typical symptoms are irregular periods, mood swings, anxiety, breast tenderness, but a whole host of other things. And, Monica, you want to tell us what are the symptoms?
Well, we always think about and make jokes about hot flashes also as if they're just benign, just something that we need to get through. But actually, there are so many other. I never had hot flashes when I first went through menopause. My symptoms were that I gained 25 pounds. I stopped sleeping for about 6 months, and all of the follow-on effects of that, just problems in my relationship and my mood and how I felt. But there are 34 named symptoms. There are generally considered to be around 100, that we can come up with. So it's really important that when we're in this phase of life, that when things, sort of pop up, also, new types of new anxiety, new onset of anxiety and mood cognition and brain fog and things are really real symptoms that a lot of women experience. And so basically it's the individual cocktail that you experience that makes this, so personal.
Absolutely. And I do think it's really important to just mention that when you are having a new onset of any of these symptoms, your doctor should be thinking menopause, not thinking of some exotic, odd disease, because most of the time we should be addressing, the obvious thing, and that's that you're going through a hormonal transition in your life. And Monica mentioned that vasomotor symptoms, VMS, is just hot flashes and night sweats. They are not simply a benign nuisance. There are direct health-related outcomes due to VMS. So all of the science tells us that VMS is associated with sleep disturbances, depressive symptoms, cognitive function. And really the most interesting and fascinating information is that there is a direct link to the severity and the onset of vasomotor symptoms and poor cardiovascular health and poor bone health. And in fact, they're shown to have direct impact. The worse your vasomotor symptoms are and the earlier they start, the worsening things like cholesterol, atherosclerosis, glucose metabolism, insulin sensitivity, osteoporosis, inflammation, the list goes on. So it's important to address, think of the VMS as a canary in the coal mine. Something's happening.
Well, also you want to care about it because more women die of cardiovascular disease or osteoporosis than of breast cancer.
Than anything. Yes, absolutely. And so what explains all these symptoms? Well, here, I'm not going to read all of these things on this slide, but this just gives you an idea. There are receptors to estrogen and progesterone throughout your body, on every cell of your body, from your brain, your heart, your bones, your skin, joints and muscles, your nerves, bladder, vagina. And so there's a profound influence when you have a loss of these hormones and also fluctuations in these hormones during the perimenopause period. So women often ask me and come to Alloy and they ask well, don't we need to check hormone levels? The answer is absolutely no. And this picture is worth 1,000 words. So just let's spend a minute taking a quick look at it. So the top, it shows you premenopause. So this is when you have nice regular production, a predictable period where you're ovulating. And we know exactly during the month when your estrogen is going to be high, when it's going to dip down low, right? After you have your period. So it's predictable. And then we've got the perimenopause, which is unpredictable. It's like someone threw yarn on the floor and the threads are all over the place. So no one needs to be checking your hormones during the perimenopause. They need to be listening to your symptoms, because on any one day, as you can tell from that graphic, your levels can change. And then in the postmenopausal period, after your ovaries are no longer producing estrogen and progesterone, there's no role in testing. We know what they are. They're really, really low, okay? The only role would be if you had very early premature menopause under the age of 40, you should probably just get that checked out to see what's causing that. But there's no role for urine or saliva or blood testing, and that's supported by NAM statements and every other professional society recommendation. So we've told you all these symptoms. What's one to do about it? So the standard solutions are listed here, and that's what we offer at Alloy. So the first being menopausal hormone therapy. So you'll hear me say the words MHT or hormone replacement therapy. We prefer menopausal hormone therapy because we're not really replacing in high levels your hormones. We're giving you small, low doses to alleviate symptoms and help with prevention of some chronic diseases. So the FDA has approved menopausal hormone therapy as the gold standard to treating your menopausal symptoms. And here are the 4 indications: women who are symptomatic at any age with vasomotor symptoms, prevention of bone loss and osteoporosis, prevention and treatment of the genitourinary syndrome of menopause, which we're going to talk more about, premature menopause and the resulting estrogen deficiency, regardless of what their symptoms are. So these are the primary indications, but there are many secondary benefits in your heart, your brain, skin, sexual health, and way more that you get from taking menopausal hormone therapy. The other solution is low-dose birth control pills. I like to call them the peri pill because they're excellent for perimenopause because it evens out the crazy erratic hormones that are generally happening. But I will mention that we can use menopausal hormone therapy rather than the birth control pill for some women in perimenopause too, or even progesterone alone. Vaginal estrogen is great to be used at any age. It's not systemic. It's safe for all women. And the local application of it in the vagina really helps treat things there. We do have a non-hormonal option for the treatment of hot flashes for women who cannot take hormone therapy. It's the only FDA-approved product. It's called paroxetine. And at Alloy, we also have 2 special solutions. We have an estriol face cream and amazing topical sildenafil sexual arousal cream. So we're going to talk more about those in a minute. And so I just want to say everything I'm talking about here does not come from Alloy's view or my personal view or belief. This is science. There are extremely clear position statements. The North American Menopause Society updates their position statements. The last one was last year in 2022. And their position statement is endorsed by every serious women's health organization around the world, over 25 of them. So this is science. And, I often hear women say, oh, my doctor told me they don't believe in hormones. I'm like, well, it's not a religion. Then they don't believe in science if they don't believe in offering this as an option and giving you a choice. So you guys are here probably because there's lots of misinformation out there. So why don't most women know that menopausal hormone therapy is literally the gold standard and first-line treatment option for their menopausal symptoms? Not an antidepressant, not an herbal concoction, nothing else. Menopausal hormone therapy, that is a gold standard. Hopefully many of you have read or saw in the New York Times, the groundbreaking New York Times Magazine cover article called Women Have Been Misled About Menopause. We were honored at Alloy to be mentioned in it, but it discussed this very question, like, why is this a problem? Why don't women know? Well, one of the biggest culprits was this very large study done over 20 years ago, the Women's Health Initiative, that we can do a whole webinar on separately, but I will just quickly say that it was a study that was released over 20 years ago, and it was a misinterpreted study, and it spread a lot of false misinformation, particularly that hormone therapy caused breast cancer and other things. All of those facts or all of those statements have been walked back by the original investigators. They realized that the study was misinterpreted, and also the messaging that went out from the media was really wrong and problematic. But that set off a real kind of almost like a trauma in the medical community and amongst patients, where people were just afraid, and overnight women went off their hormones. So you take that coupled with the fact that in OBGYN residency training programs, there's very little time dedicated to menopausal care, and most OBGYNs who graduate do not feel comfortable taking care of the menopausal woman. And definitely internists and other specialists have literally zero training in it. So despite very clear guidelines that I just mentioned from NAMS and other organizations, most doctors are still providing old, inaccurate information. So let's address the big elephant in the room, the breast cancer risk. This is the number one thing women say that the myth that's out there is that hormone therapy increases your risk of breast cancer. So if you learn one thing from this whole webinar, this is what I want you to learn. Menopausal hormone therapy does not increase your risk of breast cancer over your baseline risk, period. It does not cause breast cancer, does not increase your risk. In fact, this big study I talked about, the Women's Health Initiative, on the 20-year follow-up, and this is a quite remarkable statement, so let this sink in, 30% decrease, not increase, decreased risk in women taking estrogen. That's powerful. There's no other medication on the market that has ever been shown to decrease a woman's risk of breast cancer this much, okay? The preponderance of evidence tells us that menopausal hormone therapy does not further increase the risk, even in our most high-risk women. Those are BRCA1 and 2 mutation carriers, which I am one of, and so is Monica. So we can safely give menopausal hormone therapy to these mutation carriers. We often call them previvors. They've not had cancer yet, and it's not increasing their risk, okay? And very, very important to note, all hormonal therapy is not the same. So modern menopausal hormone therapy, really, the kind of the standards that we use today is a bioidentical estradiol, so not a synthetic equine estrogen that was used back in the Women's Health Initiative study. And these are FDA bioidentical hormones that are commercially available, and real progesterone, not the synthetic form. And so the data has shown that it's the synthetic form, particularly the synthetic progestin, that was associated with some theoretical increased risks. I think this is a quick slide I just want you guys to take a look at. This is CDC data on the incidence of breast cancer between 1999 and 2019. The dark arrow there represents the time when the Women's Health Initiative study was released, and all the news outlets and the media, they all scared women, and literally overnight, people went off their hormones. So if you'll see, this orange line is this almost 80% decrease use in hormone therapy, getting to the point where that trend continued, that basically 75% of women today do not treat their menopausal symptoms. They feel like they've got to kind of like suck it up because they're afraid of breast cancer. But look what happened, this dramatic drop in hormone therapy use. And look at the blue lines, the blue bars. Breast cancer incidence went up, not down. All right. So I think this is a powerful kind of visual. And one last thing, not to beat a dead horse, but the myth about breast cancer is real and women need to hear this, right? So there's 1,000 women in a theater. This is what this image is looking at, okay? And that one black dot, that one seat would be less than one additional case of breast cancer for every 1,000 users per year. It was based on that Women's Health Initiative study was stopped and scared everybody. In fact, this less than one additional case per 1,000 users, when they looked back, it was actually not statistically significant. So I would say this doesn't even apply. And note that the hormone that was being used in this case was a synthetic estrogen and a synthetic progestin. So even this very rare risk, which is actually quite reassuring if you needed to take a synthetic product for whatever reason, it's very safe. And this risk is the same to having an extra glass of wine a day, being obese, or having a sedentary life. So, and the other super interesting thing, I love to point this out to people, the Women's Health Initiative was not all bad. We got some interesting data. We found out that if you were on hormone therapy when you got diagnosed with breast cancer, you didn't have a worse outcome or a higher stage. In fact, you had a better outcome and a lower stage. So I think that's an interesting fact there too. So the big question, you've told me all these symptoms. Well, can I take this, Dr. Menn? Yes, for the vast majority of women, modern menopausal hormone therapy is incredibly effective and safe. There's a few kind of blanket contraindications that are out there. And these are like things that we should talk about. And doesn't mean that you absolutely can't take hormone therapy, but we need to have a nuanced discussion. So that would be acute active liver disease, an unexplained postmenopausal bleeding. And once we work that up and figure out what was the cause, and often there's very benign causes, you can be treated. A history of an unprovoked blood clot, stroke, or serious cardiac disease. And again, I should have an asterisk here too, because in some of these cases, you can absolutely safely have hormone therapy. And then something that is of personal interest to me, because I do have a personal history of breast cancer, there is this idea that a personal history of breast cancer is a contraindication, but really it's a nuanced conversation around the risks versus benefits of taking hormone therapy. And in many cases, women with a history of breast cancer can and do take hormone therapy. And then this is also interesting. So contrary to popular belief, these are all the conditions where hormone therapy is actually extremely safe, very appropriate, in fact, can improve these different conditions. Diabetes, high blood pressure, high cholesterol, obesity, a factor V Leiden mutation or other clotting risk, migraines with or without aura, and as we mentioned before, a BRCA1 and 2 carrier or strong family history of breast cancer. These are all conditions where it's perfectly acceptable to take hormone therapy. And if hormone therapy has been the only medication that's actually shown to prevent the advancement of cardiac disease when taken within that first 10 years of menopause. And we'll get to that kind of timing and what matters there. So, next slide. So formulation, timing, and duration of therapy, super common questions we get. So in a perfect world, it's ideal to start it when you're younger. So within that first 10 years of menopause, basically before chronic disease and kind of just chronic diseases from aging start to develop. But we also know the longer you are without estrogen, the more rapid chronic disease is going to kick on, whether it's cardiovascular disease, brain issues, certainly bone loss, and a whole host of other things. It does not mean that it cannot be started after you're more than 10 years from your period, or say over the age of 60 or 65. But, in those cases, we might choose maybe a estradiol patch versus oral, or, discuss different formulation. And this is really, really important. There is no need to routinely discontinue your therapy over the age of 65. There used to be this old idea of the lowest dose for the shortest amount of time. It's completely gone out the window. It's one of the reasons NAMS updated their recommendations this past April. They got rid of all of that language because we know there's literally no reason for you to discontinue it as long as you kind of review it with your doctor once a year, make sure it's still a great, good fit for you, but it's very safe to continue really indefinitely. And especially for the risk of osteoporosis, the minute you stop the hormone therapy, all that lovely protection on your bones, you rapidly get, bone loss starts as soon as you stop taking the estrogen. So that's important. And vaginal estrogen is safe at any age. And I think this is important, Monica. What do you want to say about this?
This is a very important thing for us because Alloy is very mission driven to really restore access for women to this safe, effective, science-backed, evidence-based treatment. We believe that women shouldn't be told you can't. So, which is one of the reasons why, even with the contraindications, it makes my skin crawl when people say, well, I can't take that, or my doctor said I can't have it because X, Y, and Z, but they don't tell you what the risks are of doing something and what the risks are of not doing something. So we believe that women should be informed with accurate information and then allowed to make the choice that works best for their personal circumstances. And that is something that we can really stand behind.
Absolutely. And I just love that this is, ladies, we talk about reproductive choice when we talk about, access to birth control and for abortion rights and, and just access to information. And this continues on our lifespan as we get into menopause. This is part of reproductive choice. So let's dive into some of these areas here. So let's talk about the genitourinary syndrome of menopause, a very unsexy term to basically describe all of the changes of estrogen deficiency on your urinary system, bladder, your urethra, your vagina, your clitoris, labia. So, it's a very broad thing. And at least half of postmenopausal women have symptoms of genitourinary syndrome of menopause. I think that number is too low. Probably all women have symptoms at some point. They don't even realize, they don't attribute it to GSM. But look at only 6% get treated. And this is a crime, okay? Because it really has a big impact on your quality of life. Let's just take a quick look at this image. I think this is really, really helpful. So on one side, you see the vaginal environment before menopause, and everything that I'm saying here about the vagina, I want you to remember in your mind, the same thing applies for your urethra and your bladder, your urinary system, as well as the external tissue, like the vulva, your labia, and your clitoris. And then look, on the other side is the vaginal environment after menopause. So you see, before menopause, estrogen allows the lining to be thick and moist with good blood flow, good nerve endings. The elastic walls of the vagina stretch easily. They're become easily lubricated. And all of that changes, with menopause. And those changes cause increased UTIs, incontinence, more prone to vaginal infections sometimes, certainly vaginal dryness, decreased lubrication, pain with sex. And that is a very vicious cycle. So it's not just dryness. When you're dry and pain with sex, then you can start to have low desire because you don't want to do something that hurts. So, kind of treating the tissue with vaginal estrogen is truly the answer. It's highly effective. It is safe for all women, breast cancer survivors, women with a stroke or a blood clot. This is vaginal estrogen that is being absorbed only in these tissues. It's not going throughout your body. So it can be used alone. It could be used with menopausal hormone therapy. It could be used on the birth control pill. We offer it in a cream form, and there's a small vaginal tablet form. It's excellent.
It works like nothing else.
It works like nothing else. So, people say, oh, well, my doctor says I should start with a vaginal moisturizer. Go for it. Use your vaginal moisturizer. It can be a temporary, lovely, solution to just make things feel a little bit less dry. But it's like putting a Band-Aid on a leg fracture. Like, it's not getting to the root cause, right? And that's what vaginal estrogen does. So here's a little anatomy lesson. The New York Times also had a very interesting article about the clitoris, and half the world hasn't, and why don't doctors study it? So go look that one up. But it highlights this anatomy here. So what we see on the outside of the vulva, you see the little tip there, the red glans clitoris, right? That's the only part of the clitoris that is visible to the outside. But underneath that skin literally is this huge structure that is very responsive to estrogen. Its job is to fill with blood and become engorged, just like a penis becomes erect. And the tissue then, because it becomes engorged with blood, it can produce lubrication, and all of this, all that red structure of the clitoris, this is all sensitive tissue. And this is why for arousal and to feel good, it's not just touching on the clitoris, it's touching all around the vulva. So it's just important for women to understand anatomically what's happening, and understanding that the lack of estrogen shrinks and, affects this, just like I said, it does on the vagina. So here's one of my favorite slides of all time. It's comparing the clitoris to the penis, right? Literally, they come from the same embryologic origins, right? So the tip of the clitoris is like the tip of the penis. The body of the penis is like the two branches of the clitoris going down right underneath your vulvar skin, right? So when we lose estrogen, we lose vascularity, sensitivity. We can treat, ideally, we want to at least treat it with vaginal estrogen, because we can't really help you if it like hurts and it's dry, right? So you need to start there first. And if you are well estrogenized there, we can enhance it. And we're really proud at Alloy that we are offering a prescription to topical sildenafil cream. And that's in the product called Amazing, a sexual arousal cream that we offer. And basically, in addition to obviously hopefully you're well estrogenized with your vaginal estrogen, but this will help enhance things, because sildenafil cream is the same as Viagra, right? We've spent billions of dollars over the last 2 decades, supplying men with this with
5 years.
No access to him. The US government, the US military spends close to $1 billion. I don't know, it's like $100 million or more a year on supplying Viagra just to the male soldiers. Okay. When we don't have access typically to it for women, and the structures are the same. So what we have found, and there's tons of science, supporting, and the data showing that topical Viagra, when applied to the outside externally of the clitoris, and the labia, within 15 to 30 minutes, it causes clitoral engorgement, increase in being receptive to arousal, and increased sensitivity, which then in turn increases more lubrication and can help enhance your ability to orgasm. So it works lovely.
It's a good tool.
It's a good tool. So skin health, perimenopause, and beyond. So just everything I just told you about the vagina and the clitoris, let's take it uptown to the face, right? So, in the first 5 years of menopause, 30% loss of collagen, and then you continue to lose it 2% per year thereafter. Collagen is the main support structure that keeps your skin plump. There's also a decrease in other things, elastin, fibroblasts, hyaluronic acids that your body naturally produces, which helps encourage and retain moisturization. And also the very important vascularization, keeping good blood flow to your skin, which helps make it healthy. So you can see in this image, the difference between, on one side, a premenopausal, and on the other side, postmenopausal skin. It gets thinner, less blood vessels, less collagen, right? And guys, think about, what do women spend thousands of dollars injecting into their faces? The two things that your body naturally produces: collagen and hyaluronic acid. The science is extremely clear, has been there for well over 50 years, that systemic hormone therapy, estrogen, has profound benefits on your skin. It is not the primary indication that we prescribe systemic hormone therapy for. If you're taking systemic therapy for your menopausal symptoms or prevention of osteoporosis, this is a lovely secondary benefit. But we can take it one step further. We have developed a topical, just like topical vaginal estrogen, a topical estriol face cream that is also local, not systemically absorbed, and basically stimulates the estrogen receptors in your skin and improves collagen buildup, helps with wrinkles, helps attract moisture to the skin, and really restores, all of the things that your body can naturally do for itself.
I just want to jump in that we came out with this product after I accidentally became incontinent from too little systemic estrogen and started peeing in my pants. And after like a week of using vaginal estrogen, all of my vaginal symptoms went away. And I thought, what would happen if I put this on my face? And I started using vaginal estrogen cream on my face for like 5 months. It was unbelievable. The difference in the texture of my skin, the size of my pores, wrinkles going away, the firmness and stuff. And so we this is something that's out there. It's science that is available and has been done. And we wanted to make this accessible for women. That's the Alloy mission.
Absolutely. And yeah, and like as Monica says, the science has been there, it's been there for decades, but just like the Women's Health Initiative scared away doctors and women from using safe menopausal hormone therapy, it also scared away anybody in, in pharmaceutical research to do anything with estrogen, and really to our detriment, right? This is something safe, science-based, and we
Really effective.
use it on our vagina, we can use it on our faces. So that's going to wrap the presentation up. We're going to open up for questions, and Monica, you want to talk about the
yeah, so I will go through all of the questions now. We have a bunch in the chat. Also on the screen, we have this offer web 25 off for $25 off your first order. So one of the questions actually is, can you get Amazing and M4 face cream if you already take menopausal hormone treatment? Yes, you absolutely can. You can order them separately also from Alloy, or you can order them in a bundle with the systemic hormones or whatever treatment is right for you. So
I'm going to stop the share, Monica, so we can go to full screen. Okay.
That sounds good. So how do you explain to your partner that not wanting to have sex is not about them? I mean, do we all live the same lives? It's so crazy. I get so tired of the narrative switching to them feeling undesirable when I don't have desire and don't feel good. I've tried to explain that if I were sick with something that you could see, I would probably feel more supported, and sex is really the only way for is sex the only way for intimacy? I feel like for men, it is.
Wow, that's like such an important question. And this is why it's really, really important for women to have access, one, to feel better. Because if sex hurts, if you're not sleeping at night and you're exhausted by the time you go to bed, you're not going to want to have sex, right? And I think this is where, education is really important. So, maybe letting your partner watch this webinar, because I think we're going to have, this available, down the road for viewing. And I think that, a partner who's worth having sex with is a partner who is willing to, sit down and listen to, this information.
But also, that's so difficult. It's absolutely true, but it's so difficult to, sometimes with men, we've all been there.
Yeah, we understand, but
it's really having been there very specifically myself and understanding this question firsthand, I think making sure that you feel well and that you've treated your symptoms, and ultimately, like I had the same conversation when I had to wake up sort of with my husband, like, hold on, this actually really isn't about you. This truly is physical. And so I'm going to need to deal with that, and then we can deal with ourselves.
And one little tip I've told patients is, like, actually sometimes going to them and be like, listen, I get it. Like, sex is really important for us to feel connected. And I want to tell you what I'm bringing to the table. I'm taking it upon myself to go to a doctor, to get information, to kind of like think about how I can help myself feel better. So I'm doing my part because I love you and I want to be sexy with you. You need to do your part by whatever you need them to do. So that's a little tip. Sometimes they might feel more motivated to know, like, oh, she actually cares and she wants to do something about this. But
we've gotten a lot of questions, and if we don't get through them all,
yeah, let's keep on going.
Yeah. So can oral estrogen minimize or reverse thinning hair? If not, what do you recommend for treating the symptom? Does Alloy have plans? Yes, we do, to offer a product that addresses the symptoms specifically. We do.
Yes. And yes, absolutely. The loss of estrogen, just like it changes, skin changes, hair follicle changes, menopausal hormone therapy may help. It can help a bit with that. But we are looking into there's definitely science-backed options that we're going to offer.
Okay. When is it too late for HRT? Is HRT contraindicated for those with family history of cancer? We sort of answered this.
Yeah. So it's never too late to start, but it's just a different risk benefit analysis. For instance, if you are 68 years old and you're more than 10 years from your period, we're just going to, the main thing is, in the older women, we often just will recommend that you use a patch, a transdermal, because it eliminates any risks of very rare blood clot risks in older women when they take oral estrogen. But really, it's never too late.
Yeah. Is there a treatment for burning mouth?
Yes, menopausal hormone therapy, because burning mouth is interesting. One of those weird symptoms of perimenopause and menopause that a lot of women talk about. It probably has to do with, again, the loss of the integrity of the skin inside your mouth.
Yeah. And what about poor thyroid function?
Yes. So autoimmune diseases are associated with the menopause transition, and there's strong suspicion that that loss of estrogen interferes with, how your thyroid functions. So we often see it go hand in hand. Menopausal hormone therapy is not contraindicated and may actually improve your ability to deal with your thyroid disorder.
Have you heard of neuropathy and RLS with menopause? I've had this in a bad way. After thousands of dollars of tests, I Googled low estrogen neuropathy, and lo and behold, there were studies. So frustrating to see 3 doctors and no one thought of this. Estrogen has almost made it completely go away.
Absolutely, positively. There's incredible research out there on particularly the kind of the rheumatologic diseases and neurologic diseases, MS, rheumatoid arthritis, different neuropathies, and there is a strong association. I've had many women, it's not the cure-all if you have MS, but it certainly may help, or if you have one of these neurologic diseases. So absolutely.
Does progesterone do more than just protect the endometrium? If so, how else is it beneficial? This is a great question. If not, is using it vaginally sufficient if using an estrogen patch or pill?
Yeah, progesterone is super, super important. You absolutely have to have it if you have a uterus, because otherwise unopposed estrogen can make the lining a little bit thick. But it's good for more than just that. Otherwise, your body wouldn't spend all this time making it through most of your life. Progesterone in particular, very, very helpful for sleep, anxiety, the mood changes. Also super, super helpful in perimenopause when you have a lot of estrogen being produced and you're not always ovulating and making progesterone. So that's really lovely there. For women, there's a small percentage of women have a hard time with oral bioidentical progesterone. We can safely dose it vaginally because it gets absorbed right into the uterus and protects that lining from the estrogen. And so that's another way.
Literally like a capsule. I've used I either take it in by mouth or I put it in my vagina kind of capsule.
Yeah. It can work either way. Ideally, we do it orally because that's where you get the benefits for the sleep and anxiety.
Well, and also one thing to note that the North American Menopause Society in their updated protocols said that 300 milligrams of progesterone can be used, is clinically indicated for sleep. And so what about women who've had a hysterectomy? Can they also still take it even if they don't have to take it?
Absolutely. So, I often will start a woman on just the estrogen because they don't have to have the progesterone. But if their symptoms aren't completely relieved, or they are relieved and they're just curious and they want to give it a try and see if it helps, totally safe. Do it all the time.
That's actually a really important point, that like a lot of this stuff, you can try it. And if it helps, that's the answer. If it doesn't help, then no harm, no foul. You can try something else, but
things are out of your body. You have to take it every day because it's out of your body in 24 hours. So there's no long-term effects. If you try something, it's not right for you. And remember, we start with something, we can change dose, we can change formulation, we can change regimens.
I've read a lot about skin, hair, nail, etc. changes. My hair was curly my whole life, but over the last few years it's becoming straighter. Is there anything at all that can restore my hair back to the way it was? It may sound a bit whiny, never, but I miss my hair the way that it was. That's why we're working on hair.
Yeah. And I think that, the changes in your follicles definitely impacts that. Yeah.
Yeah. And so that is estrogen related, or loss of estrogen related. And there are ways that, taking estrogen could help with that, but also there are other things that could help even more, or in addition. I seem to develop melasma when taking estrogen. That's when you get dark spots. Is that, or like what sometimes is called pregnancy mask? Is that temporary until my body adjusts to a new hormone level?
Melasma is tricky and it's very individualized. This comes down to receptors. Like we all have receptors in our skin, everywhere else to estrogen. And, for some of us, our receptors could be quite sensitive to hormonal fluctuations. And that's why women get that mask of pregnancy. It can be temporary. If that's something that's a concern, I would suggest you start with like the very lowest dose and, we kind of take it from there.
This is the question. Can I purchase Alloy's M4 estriol face cream or Amazing cream if I'm already taking a prescription HRT estrogen patch progesterone pill prescribed by my doctor? Yes, you.
Yeah. There's no contraindications of using either of those local, medications with really any other medication that you're taking.
Yeah, the topicals like the vaginal cream and the face cream really only hit the estrogen receptors in your skin. It doesn't go into your bloodstream. I'm almost 43 and my new doctor offered me everything but MHT. How do I convince my doctor to prescribe me MHT when I have peri symptoms?
Well, clearly that doctor is not well educated on, perimenopause. You can print them out a copy of the North American Menopause Society statement, or you can come to Alloy and we'll help you out.
Are testosterone pellets safe?
No, and no. Testosterone and androgens can be an important part, and it's an evolving kind of thing. And hopefully one day we might be able to offer it. But pellets are not safe, and they kind of came about because of women being denied access to safe, effective, guideline-approved hormone therapy. So what's a woman to do? They wind up going to doctors who promise them the world and inject pellets. They're unsafe because they're not standardized, they're not FDA approved. Once they're in your body, they're very difficult to remove, and you can have super physiologic, very, very high levels of testosterone that can be quite dangerous. There's no safety data on it. And what I tell women is, if we treat your menopausal symptoms with estrogen and progesterone, as per guidelines, many women find they don't need the testosterone. And another little tidbit people understand, in your body, your fat cells, there's enzymes throughout your body that take the estrogen and the progesterone and do convert it to low levels of androgens, DHEA, and testosterone. So by doing the hormone therapy, you're probably addressing those needs. And for the small percentage of people who might need testosterone, there are actual guidelines on prescribing it, but none of them include pellets.
I had pellets and I had the super physiologic dose of estrogen, testosterone, and it was a little scary actually. So I'm not.
Yeah. And if you notice pellet therapy doctors, they don't take, they charge you a ton of money, and they have you come in for all fancy testing.
Millions of dollars. And
not worth it.
I was searching. That's why Alloy came about, because I tried everything. So she's been in menopause 3 times. I've tried everything. We know a lot. Do we accept insurance for these hormone pills, creams? Right now, we don't, although we have tried to really keep our prices at a very accessible level. So it's more or less what a copay for insurance is. It's something that we're working on to be able to get the FDA approved prescriptions available through your pharmacy, and then be an Alloy member to have access to the expert physicians. But we're a young company and we're working on it. So not quite there yet. Is a woman eligible for hormone therapy if she's more than 10 years past her last period?
Absolutely, yes. And very often in those cases, we might suggest that you use the patch rather than the pill. But yes, absolutely.
It won't, if you have, let's say, heart disease already advanced, it won't solve those problems, but it will, it has been shown to really improve symptomatology for women who are older and have been out without estrogen for a longer time. Can you use sildenafil with HRT?
Yes,
Yep.
yes.
Okay. Does vaginal estrogen need to be inserted or used on the labia and vulva? I've tried inserting it and it stung pretty bad.
So a couple of things. So ideally it is inserted into the vaginal canal, because it gets absorbed into, the surrounding structures. And then you can, in addition, use it externally. There are some patients who are very sensitive to the estrogen cream, and it probably has to do with how dry their tissue is. So we do offer the generic version of Vagifem, which is a little small vaginal tablet, which you insert up inside. And for women who are very, very dry and sensitive, they can start with external application and the much maligned vaginal moisturizer. Not maligned, but it's not, helping the problem. But you can use like a healthy amount of like organic coconut oil or a nice simple vaginal moisturizer to just help make the tissue a little bit more receptive to having this new medication. But we can work with you to make it happen.
Yeah. Can I use the Amazing cream if using MHT and topical testosterone?
Yes,
Yep.
yes.
Yeah, the Amazing is just, it's Viagra. for
And it's
top.
short acting. I mean, it's, you know, it kicks in 15 to 30 minutes, maybe lasts up to 2 hours. Then it's out of your system. It's only locally applied. Women always ask, this question might come in, can I have oral sex with it? Yes, let it kick in. It takes about, like I said, 15 to 30 minutes to kick in. So it says, you know, apply it, do your, you know, do whatever you want to do. You want to do your little skincare regimen, or you want to, you know, listen to some erotica or do something that's going to get you in the mood. Let it kick in. And then if there's a little excess cream, you could always just like wipe it off with a little wipe or a cloth. It's not going to hurt your partner. Men take it in much higher doses orally, so it's fine.
Yeah, the amazing thing about it is that it's just like, it's for your pleasure. So if it helps, great, but it's definitely not going to hurt. And there's no contraindications for anybody. With M4, would you put that on before your retinol?
You can do whatever works for you. It's safe to do it either before or after. If you have very sensitive skin and you're like, you know, you find you're sensitive to retinol, you could put on the M4 first because it helps kind of buffer the retinol, or, you know, you can put your retinol on first and then it goes on top, whatever works for you.
Yeah. I think I'm going to skip the question about Nutrafol pills for hair growth because I don't think that we're experts on, those are supplements. We're not really experts on other supplements like that. But is HRT in patch form safer than a pill?
For the far majority of younger women without any, you know, significant serious medical conditions, both are safe options. The estradiol pill is less expensive. Some women love the ease of the pill. And the main risk that we think about with an estradiol pill versus the patch is that there's a very, very rare but known risk of increased risk of a blood clot, say in like a leg or an arm, that could then, you know, travel to other parts of your body, like your heart or your brain, and cause a stroke or, you know, a pulmonary embolus, which is obviously very scary, right? That risk is really only significant for the older woman over age 65, or certainly definitely over the age of 70, or women who have comorbidities, like you have, say, significant hypertension or a blood clotting disorder, or you have, you know, advanced diabetes. In those cases, we're going to say, let's just avoid that, even though it's a rare risk, altogether, and go right to the patch. But if the patch is not something that you desire, or, you know, it is a little bit more expensive, you should feel very safe taking the estradiol pill.
Yeah, I think my own experience, I mentioned that I've tried everything. And I think part of what a lot of women don't really know or aren't told is that the form is very personal and flexible. So as is the dosing, actually. Like if you don't feel that your symptoms are being relieved by a certain dose, you can generally go up. Like there's very difficult to overdose on these hormones. It really is about what is the right amount that solves your personal issues and makes you feel the best.
I just want to jump in about the clotting thing in the oral, because this is something, a very, very, very common thing. One thing to understand is that clotting risk is only present for the first year that you're on it. Okay. So it doesn't like increase the longer you're on it. So if you're on it, you're doing great. You shouldn't feel bad about being on the pill. And the other thing is your risk of having this same type of blood clot is like, I don't know, 5 to 10 times higher if you ever got pregnant. It's certainly higher on the birth control pill. So we don't tell women not to take the birth control pill, and we don't tell women not to get pregnant. So you shouldn't be afraid of taking a low-dose estradiol pill.
Yeah, I think that is really important perspective to put it into for women.
Yeah, you got to put it into perspective. Yeah.
So then the answer to, if you're taking an oral estrogen and progesterone and it's working for you, you should not necessarily switch to topical. Also, topical is different than transdermal, just in terms of the lingo. Typically topical is referred to like as the cream, for example, the vaginal cream, or the M4 face cream, which is a compounded cream. The only other systemic topical cream for estrogen is compounded, which generally, when there's a commercially available FDA approved alternative, it's preferred and certainly recommended by the North American Menopause Society. And with progesterone, as I've learned from my Dr. Menn medical school, the molecule is very large. So typically you wouldn't use progesterone transdermally, or you need to figure out how to dose that.
Yeah, that's why the only FDA approved products for progesterone is oral progesterone, or if you don't tolerate oral progesterone, we can give you a synthetic progestin. But topical progesterone in these compounded creams are not reliably absorbed. They may not be protecting the lining of your uterus. And so that's why you shouldn't use those for systemic hormone therapy.
Okay. Here's another question about, so I did gain a lot of weight, and I did actually lose the weight. It took me a while. I think really trying to lay off processed foods and sugar as much as possible is, a big key to it. But also the thing that I've learned in the last 2 years that I never really realized is how under muscled I was, and most of us are. So actually strength training, well, the first thing is that I took estrogen. So that was the first thing, is like I gained all this weight because my body basically went into shock after my ovaries were removed and I stopped making estrogen. And we know that when you lose estrogen, that the distribution of fat changes, the type of fat that you gain changes. So more adipose fat around your middle. I had all of that. And it's definitely harder to lose. But the thing that has really enabled me to change my body is strength training. And also I've pretty much just adopted intermittent fasting in the last few years, where I sort of make lunch my first meal, and I find that I'm less hungry and I make better choices. So
yeah, and I just want to jump in because women always ask the doctors at Alloy, or in, just doctors in general, when does menopausal hormone therapy cause me to gain weight? No, all the data, the science tells us it does not make you gain weight. They also ask, well, will it make me lose weight? And well, I say, kind of jumping on what Monica just said, I say menopausal hormone therapy is part of a toolkit in managing your weight. So if you're not sleeping, your metabolism goes to crap. If you are stressed and anxious, your metabolism changes. You're also more prone to making poor food choices and not being able to exercise. When you lose your estrogen, you lose muscle mass. When you lose your muscle mass, your metabolic rate drops. So that's why people are like, wait, I'm eating the same and I'm still gaining. I'm like, well, because you're rapidly losing your muscle mass. And what Monica says, you are metabolically the lack of estrogen, I should say, drives your fat to not just like the outside of your belly feeling fat. It's what you can't see on the inside, is you actually get fat accumulated around your organs. It's called visceral adiposity. And that creates an inflammatory state where you get insulin resistance and worsen glucose metabolism. So metabolically, the estrogen loss is setting up changes that are antagonizing your efforts. That's why you could be doing the same thing, you're being antagonized. And what Monica says, by adding estrogen, it helps with the metabolic process. It helps you preserve your muscle. But Monica said it's so important. You have to build lean body mass by doing like some lifting. And yeah, so anyways.
It doesn't make you big. It actually makes you tighter and stronger and able to eat more things because your muscles are actually burning up the food.
Absolutely.
I'm using Alloy's vaginal estrogen and it works great. I'm so glad to hear. Instead of buying your new product for my face, how often can I use the vaginal estrogen on your face? Well, my experience is that you can use it, the dose is pretty much the same, but the cream is different. So I use it every day. I sometimes use it a couple times a day, but what I found is that the vaginal cream is just not as nice of a cream base for your face. And that's why we reformulated it, but it works well.
Yeah, essentially very, very similar.
Just get a second tube so that you don't starve either place of the estrogen that you need.
Exactly.
What do you think about ISTIM internal vaginal TENS, like stimulators to exercise Kegels and your muscles in your vagina?
Yeah, I was just at the International Society for the Study of Women's Sexual Health, ISWISH conference. And, there's definitely a lot of talk on that. I think a lot of these new devices, you have to really look at the science. Some of them don't have, placebo-controlled sham trials. There's probably some, a decent amount of science supporting that. I would just say pelvic floor therapy, these devices, these energy devices can be helpful. But if you're not treating the estrogen deficiency of your pelvic floor, then, it's not worth you doing those things.
I don't think we're going to have time to get through everybody, but there's one question. I'm 39 and don't have a uterus. I'm already on Alloy estradiol. Why was I not given progesterone? I think we hit that, but if it's something that you weren't given it because it's not the standard protocol to give women who've had a hysterectomy have had their uterus removed progesterone. But if it's something that you think you might benefit from, you can message your doctor and you can
absolutely ask. It's just that it absolutely has to be given if you have your uterus. So by default, the guidelines say, oh, you don't need it, but we do know science shows us that progesterone can be helpful. And I will just add, especially for those younger women who are dealing with the more severe premature menopause.
How do you know if the estrogen and other products are working? How is dosage monitored?
So very simple. We don't measure blood tests or urine tests because it's never been shown to correlate with symptom relief, nor is it effective in finding what's actually available in your tissue. So we treat you based on your symptoms. So if you have improvement in your symptoms and you're minimizing any unwanted side effects, most common side effects I should mention are some transient breast tenderness, some irregular spotting and bleeding, particularly in the first 6 months. Those are very, very common side effects. Once we get over the hump of the first couple of months, they tend to go away. So we minimize side effects, maximize your symptom relief. And so if you're not having a lot of symptom relief within 4 to 6 weeks, you need to speak up. And I would say within 2 weeks, if in 2 weeks you don't have even some modest, tiny improvement, let us know. Don't sit and suffer, because you start low and we build up. So that's how we decide the dosing.
Yeah. And here's another one. My gynecologist will not prescribe HRT until I have an ultrasound to measure the lining of the uterus, so he will have a baseline image. Is this really necessary?
No, it's actually frowned upon. It's junk science. There is not one single recommendation out there. We do not follow women with endometrial stripe measurements. That is only reserved for a woman who is having abnormal bleeding outside of the 6 month to 12-month window of being on hormone therapy, or for other reasons, but definitely not for the initiation of hormone therapy, not by any means.
I had to quit strength training because of recurrent joint pain, elbows and hips. Could HRT help control these symptoms? I'm thinking I may need to have my dosage increased. I'm not seeing much symptom relief, joint, sleep, hair loss.
Yes, absolutely. It's incredible, women with joint pain, when they are on the right dose of estrogen, how profoundly they can have profound relief, and then they can resume all of those other healthy activities.
I can attest to that from personal experience as well.
Yeah, me too.
Can I use birth control instead of MHT for the rest of my life?
Not ideal, no. So, ideally, it's great for perimenopause, but there's frankly no reason once you are past the average age of menopause, and certainly by the age of 55, for you to just switch to menopausal hormone therapy. One, it's a much lower dose, still giving you all the benefits with a lower risk, because as we age, synthetic oral estrogen and synthetic progestins, remember that's different. They're synthetic. That's just what the birth control pill is. If we gave women high enough doses of bioidentical menopausal hormone therapy to prevent ovulation and be there for birth control, they wouldn't be able to tolerate it, because we'd have to give them such higher doses. That's why there's synthetic forms. So as you age, there's a much better safety profile to just being on menopausal hormone therapy than the birth control pill at that point.
Okay, I feel good that we got through so many questions in the hour. I'm sorry for the people whose questions we haven't answered, but we will continue to, we'll figure out some way to answer all these questions and get them to you. Also, if you like this session, let us know. We're happy to do more, or open it up to your friends or your own networks. We're really all about spreading the word and using our own experience to help other